All right, good afternoon, everyone. This is the posted time and place for the Silver State Health Insurance Exchange for their advisory committee, which is the Plan and Certification and Management Advisory Committee. We are teleconferencing here in Carson City at the Legislative Building and also at the, it looks like, oh, we're at the Grant Sawyer Building down in Las Vegas. And we have some people joining us by phone, and it sounds like somebody's trying to say. Okay. All right. For those of you joining us on the phone, can you please mute your phones because we can hear conversations going on in the background? That's me. Okay. All right. So with that, I'm going to call the meeting to order and ask Mr. Hager to do the roll call for us, please.
Dr. Ahern?
Present.
Dr. Jackson?
Present.
Mr. Finch? He indicated he would be absent. Mr. Mathias?
Present.
Ms. Mayville?
Present.
Dr. Roberts?
Present.
Mr. Woodley?
Present.
Dr. Klein?
Present.
Chair Campbell?
Present.
We have a quorum.
Thank you very much. I don't have any announcements this afternoon. Mr. Hager, do you have any announcements that need to be made?
If you're on the phone, as the chair indicated, please make sure your phones are muted. Also, please do not put us on hold so that we don't have to listen to the elevator music. I appreciate it. Thank you.
Thank you. All right. Agenda item number 2 is public comment. Dr. Klein, can you help me find out if there's anybody in Las Vegas that would like to participate in public comment at this time?
Sure, Madam Chair. I see no public comment.
Thank you. How about here in Carson City? Any public comment?
And Madam Chair, as they're coming up the table, we had 3 public comments. One was from Mr. John Sasser, and then an updated document from Mr. Sasser, and then another one was from DeVita.
And as posted within the meeting, public comment will be limited to 3 minutes. Thank you. If you'll identify yourself for the record, please.
Yes, thank you, Madam Chair. For the record, my name is John Sasser. I'm the statewide advocacy coordinator for legal services programs in the state and representing today Washington Legal Services and the Legal Aid Center of Southern Nevada. As Mr. Hager referenced, there are 2 pieces of testimony online. One that was resubmitted from August 20th, in which I'd made 5 suggestions to the committee in an attempt to balance your obvious concern with not limiting the playing field, not knowing what the market's going to be, and have people come in and participate in our new exchange, and some concerns with consumer protection and meaningful consumer choice. My new testimony, which I put in there today, is those same 5 suggestions but modified somewhat based upon both new information and upon the actions this committee took, which were approved by the full board. I'm not going to read that testimony, but just very briefly make a few points on those 5 suggestions. First suggestion had been made that any plan management policies adopted by the board be time limited to 1 or 2 years and be revisited. You have said on many occasions that you'll be continually monitoring the decisions that you've made, particularly the one about not having any standardization among the plans. So I renewed that suggestion and amplified it a little bit by saying, in addition to just thinking we're going to reevaluate some point down the line, in order to do a meaningful revaluation, it's important to collect the data along the way that you're going to need to look at that time. And second, if there are any studies that you might want to be doing in the meanwhile, while you're waiting on that year or 2 to pass, as some of the other states are doing on standardization, you might want to engage a consultant or piggyback on other states' work in this regard. So when you're revisiting a year or 2 from now, you'll have the information that you'll need in which to reevaluate. I had also withdrawn somewhat suggestion that that there be a standardized plan offered in all tiers, since you don't have a standardized plan to offer, but continue to raise concerns around especially the use of co-insurance in plans where consumers really don't have any knowledge of what they're going to be getting. That there's a lot of consumer confusion around co-insurance. Anything you can do to limit that and move to something that's more knowable, like co-pays, I think would be a helpful thing to keep in mind, or at least to study for that year or two revision down the road. I had suggested that there be HQPs offered in all metal tiers, so to avoid adverse selection within the exchange, to make sure that there are the plans available for the younger and more healthy persons, so they are in the exchange and participating, and also to take a look at those plans that are offered outside the exchange, so there's not adverse selection between within and without exchange. I was privileged to get a copy of an email from Mr. Hager to Mr. Mathias in response to that one, saying that in his conversations with the insurance commissioner, they're always looking at these adverse selection problems and evaluating them and are studying them. I would love that if some of that came back through the exchange so the public could understand that and participate in it. Finally, I drew number 4 based on the actions of the board. Finally, I'd said that this exchange has, and this is under item 5 today, the obligation to make sure that when you're certifying plans that they don't have discriminatory effects in them. I think we've already discussed when you picked your benchmark plan, the whole issue of the only habilitative services that we're offering is those for people with autism, that arguably discriminates against people who need habilitative services due to other conditions such as Down syndrome, and is also limited to people under age 22, and whether that might create an age discrimination for habilitative benefits. So in certifying these plans and looking at plans that might come in that are substantially equivalent to the plans that is your benchmark, just wanted to remind you of that concern and ask that you address it. Thank you.
Thank you. Appreciate your comments, and also for putting it in written format so that we can post it on the website.
Good afternoon. My name is Elisa Caffaretta, and I am the president of Nevada Advocates for Planned Parenthood Affiliates. Just want to echo again that we are supportive of John Sasser's public comment to you, and we've put that in writing several times. I told him we didn't do it this time, but I think every time he's had a letter into you, we've also had one saying we agree. That's great. One thing that I would like to flag for either your discussion today or possibly the regulations is the importance of making sure that as we move forward, insurance companies will set up contracts with all essential community providers going forward. Currently, we're setting up contracts with insurance companies in Nevada, and at least one that I know of has said, we're not going to set up a contract with you. We'll call you later if we need to do it. I was talking to a solo practitioner doctor this weekend at a birthday party, and he said, yes, we have that same exact issue. We want to make sure that the insurance companies all will contract with us if we are willing. So I did not put together language. I would be happy to do that for you for a future meeting, but something along the lines of, to be certified as a qualified health plan, a plan shall, at a minimum, include within the health insurance plan all networks, include within the health insurance plan networks all willing providers or all essential community providers. So I will provide that in writing. Again, I'm not sure if that's a policy level decision or a regulatory level decision, but we look forward to discussing that further with you. Thanks so much.
Thank you.
Thank you, Madam Chair and members of the subcommittee. For the record, my name is Chris Ferrari on behalf of DaVita. We have submitted our letter to the committee as well, and it's available on your website, but I wanted to highlight a few things within the letter. The DaVita patient population includes more than 145,000 patients who have been diagnosed with end-stage renal disease or kidney failure, a group representing approximately one-third of all Americans receiving dialysis services. DaVita has the privilege in Nevada of providing dialysis treatment for over 2,000 individuals with kidney failure throughout its 22 centers across the state. ESRD, as I mentioned, or kidney failure, is the last stage, or stage 5, of chronic kidney disease. This stage is reached when an individual's kidneys stop fully functioning and therefore cannot sustain life. We want to ensure that these vulnerable populations, including the folks with ESRD, have a clear network adequacy standard. We appreciate the opportunity to comment on additional qualified health plan criteria relating to network standard adequacy. As you are all aware, the Affordable Care Act states that the Secretary of Health and Human Services shall, by regulation, establish criteria for the certification of health plans as qualified health plans. Such criteria shall require to be certified. A plan shall, at minimum, ensure a sufficient choice of providers and provide information to enrollees and prospective enrollees on the availability of in-network and out-of-network service providers. Guaranteeing network adequacy is a particularly important issue for those with ESRD. As someone who is receiving dialysis, their life depends on their ability to get this access at least 3 times each week, and as most of you are aware, it can be very physically draining. We therefore encourage the establishment of qualified health plan criteria that creates a clear network of adequacy criteria specific to ESRD, and further defining unreasonable delay in terms of geographic distance or average drive time maximums. What we mean by that is, in metropolitan areas such as Reno and Las Vegas, we believe that plans should require that ESRD patients drive more than 30 miles or endure more than a 30-minute drive from the patient's home should be considered unreasonable, i.e. they should be able to get there within 30 minutes. For ESRD patients living in more rural areas of the state, we encourage the Exchange and the Division of Insurance to work with ESRD patients and patient providers to establish specific network adequacy requirements for the provision of care to these ESRD patients. We want to make sure that folks don't have to drive too far and therefore either endangering themselves or others. We also want to make sure there are protections should out-of-network coverage be required. In any case where the health carrier has an insufficient number or type of participating providers to provide a covered benefit, we would like for the health carrier to ensure that the covered person obtains the covered benefit at no greater cost to the covered person than if the benefit were obtained from participating providers. Thank you very much for your time.
Thank you very much. Is there anyone else here in Carson City?
Madam Chair, may I ask
Yes,
a question
Dr.
from Mr. Furry? Sir, Mr. Furry? Hi, Ron Klein in Las Vegas. Please help me with my ignorance. I thought that all patients with end-stage renal disease on dialysis were covered by Medicare as part of the ESRD program. Is that not true? And if so, it wouldn't be part of the exchange.
Sure. Thank you, Dr. Klein. There's actually anybody can be covered by Medicare. There is also an opportunity for all patients to have a 30-month continuance of existing coverage within their private insurance. So it's not a default into Medicare, it's the patient choice.
What you're saying is that after 2.5 years, after 30 months, they generally go to the Medicare program?
Yes, they do.
Medicare program.
They default to Medicare
right.
at that point, but the patient, upon diagnosis, has a 30-month window in which case they can maintain their private coverage.
Do you have any idea of your 2,000 patients in Nevada, how many have Medicare and how many have private insurance?
I don't have that information, Dr. Klein, but I can certainly find that out for the group. Thank you for the question.
Any other questions, Dr. Klein?
See none. Thank you.
Thank you. Is there anyone else here in Carson City for public comment? How about on the telephone? There being none, I'm going to close agenda item number 2 and move on to item number 3, which is the approval of the committee meeting from September 13th. If the committee members have had a chance to review those minutes, are there any additions or corrections or edits?
Move that the minutes be approved as submitted.
Okay, so we have a motion by Dr. Jackson. Who?
I'll second.
Okay. Larry Mathias with the second. All those in favor of the motion?
Aye.
Any opposed? Thank you very much. The minutes are approved. Moving on to agenda item number 4, which is to review the status work completed by the committee. That item is also on the internet for review. And I will then turn this over to Mr. Hager to walk us through that agenda item.
For the record, John Hager, very similar to what you've seen in the past. This is simply an update to the previous documents. You can see the calendar on page 2. We are moving basically to the last item, which is the certification criteria and processes, which we'll discuss in agenda item number 5. The rest of the information is very similar to what you've seen. The recommendations that have been approved by the board include the key principles, the Division of Insurance to conduct the rate review, offering the same QHPs in the individual and shop exchanges, or not offering this, allowing carriers to not offer the same plans, whether or not standardized plan design and cost-sharing benefits, and then the number of QHPs offered by each carrier in a given tier. With that, I'll be happy to take any questions you might have.
Any questions from Las Vegas? Any questions here in Carson City?
I have one, Madam Chair. Larry Mathias, have we got any clearer timeline from the feds on when they expect to issue further guidance and regulations?
For the record, John Hager, the answer we've heard is soon. My understanding is we can expect a bunch of regulations to come out in the middle of November through the beginning of December. I don't know if that timeline will hold depending on election results. I don't know if it will hold regardless of those election results, but that is the latest word that we've had, is that mid-November through early December we should get a set of regulations. The difficulty then will be reading and interpreting hundreds of pages of regulations, but at least we'll have something to look at that point.
Any other questions?
One question for John. John, so we all know, just will you clarify for us that the Department of Insurance, Division of Insurance, elected not to pick any of the 3 criteria, any of the 3 plans we forwarded to them. So by default, we picked Plan A. Is that correct?
That is correct.
Will we then also pick the supplemental dental plan that we voted to include if A was picked, as per Mr. Mathias's resolution, or?
I'm not sure if I recall. It would actually default to the FedVIP dental plan. However, that is simply the default submission that will go to HHS. HHS will then turn around and write that up and will be available to the public for comment. The state could at that point provide information to update its recommendation and could include the CHIP program, the CHIP recommendation with Plan A or another plan if that's what the Division of Insurance decides. So there's still an opportunity to be able to make those changes.
Any other questions? No, in fact, Mr. Hager, do you want to walk through that process on that default, just so people that haven't, it's been a while since we picked that issue up.
Sure. For review, so the committee went through an extensive process to review the plans and provide input to the board and a following recommendation to the Division of Insurance. I believe that significantly helped the Division of Insurance look at all the different plans, narrow it down. The Division of Insurance went through a stakeholder process. I think they had 4 or 5 meetings throughout the state and received a lot of input. They then reviewed the items and determined that there was insufficient information to provide a single recommendation. As you recall, we provided 3 recommendations. The concern, of course, there's several concerns, but one of the concerns is the definition of discriminatory benefit design, of which we don't know what that means exactly. There's a few other issues, such as what does it mean to be what does pediatric coverage mean? Is it an age limit? And various other questions. So the Division of Insurance elected not, and I don't know exactly all the reasoning, but those were among the reasons of why they elected not to provide a recommendation. So therefore, the default plan, which is the largest small group employer plan by enrollment in the first calendar quarter of 2012, becomes the benchmark plan for Nevada's essential health benefit package for 2014 and 2015. It becomes the default recommendation to HHS. At that point, HHS will write up all 50 states, or 51 when you include DC, default plans or recommendations into a single document that the public can comment on. Similar to any other regulation, they will have 30 to 60 days to comment on that regulation, and then based on those comments and other items, the Department of Health and Human Services, the Secretary, will then determine what the essential health benefits package will be for each of the 50 states plus the District of Columbia.
All right, then we will go ahead and close agenda item number 4 and open up agenda item number 5, which is the discussion and possible action for certification of qualified health plans.
For the record, John Hager. So item number 5, the certification of qualified health plans, has a number of items, 11 different items on it. And a lot of the items are currently in review. And so while this is before the committee today, we wanted to provide an update on where some of those items were and the basic idea of are we going in the right direction or do we need to do this differently? So that's the basis of this report. We basically went through 45 CFR sections 155, 1000 through 1080 and hit all of those pieces. What this will do is allow the committee to determine how it wants to proceed, possibly make a recommendation to the board, and then we can provide that information in our blueprint that we submit, that's required to be submitted by November 16th. It doesn't have to be completed information, but a timeline that shows how we're going to get to a completed process. One of the important things about this is, of course, the timeline for certification. We are working with our IT vendor, Choice Administrators and Xerox State Healthcare LLC, to determine how far in advance of October 1st, 2012 they need the information from the plans to be able to get them onto the exchange. And we've asked for we've received a draft calendar. We're going to go over that with them, and it'll be an iterative process over the next few months. But we want to give the carriers as much time in advance to allow them to understand when they're going to need to be available to input their information into the system or provide information for Xerox to input. So there'll be an onboarding process with specific dates. So that's on the back end going from October 1st forward. On the front end, of course, is the Division of Insurance and their processes to certify a plan. There's obviously the rate review process, which this committee and then the board have recommended that the Division of Insurance conduct with their current rate review process, and they'll make sure, and we'll work with them to make sure that all of the requirements of the Affordable Care Act and the exchange are included in that rate review process. And there's a recommendation in here to allow the Division of Insurance to do the plan certification process as well, which they are really in a position to be able to do. So we work with the Division of Insurance to determine the certification process timeline and how long that will take to make sure that we have enough time getting to when we come together between the Xerox requirements and the Division of Insurance requirements. And so we'll work through that timeline with the Division of Insurance and with Xerox. So on page 2, the certification standards, you can see the requirements by the regulation. Again, the board approved as one of the key principles to be a market facilitator. As a free market facilitator, We would provide a general structure capable of facilitating market competition, establish basic rules for buyers and sellers, and serve as a source of reliable, impartial, transparent information about the available plans. It is expected that the free market facilitator model will ensure the maximum participation by insurers and the widest choice for consumers. Therefore, it also follows that any carrier that wishes to obtain a certification for a plan as a QHP may do so as long as the QHP meets the requirements of the exchange, the Division of Insurance, and the Affordable Care Act and its regulations. So the recommendation of staff for this item is to determine that, notwithstanding any requirement or limit to the contrary, any health plan that meets the requirements of the exchange, the Division of Insurance, and the Affordable Care Act and its regulations be certified as a QHP to be offered on the exchange. And Madam Chair, would you like me to continue through the whole report and then we can hit each of these separately?
What is the pleasure of the committee? Do you want to ask questions after each of the 11 items?
I think we should go through the item and approve it as it's being discussed.
I think it would
that's
be
a lot
easier.
less confusing.
Yeah, I think so too. All right, so let's open it up for discussion then on the certification standards. Any questions in Las Vegas?
Yeah, I would, Ron Klein in Las Vegas. I do agree with Mr. Sasser's point about time-limited standards. I think there are people, on the exchange board who feel that, who are ready to go with a free market standard because we don't know what's going to happen and we want to have maximum possible participation. But revisiting those standards in 2 years, once we're up and going, I think is a very reasonable statement. So I guess I would amend that, just that we revisit this in 2 years.
For the record, John Hager. Dr. Klein, can I ask, when you say 2 years, 2 years from right now is the end of 2014, so just to be clear, you would like to revisit this in the middle of 2014 or after we have a full plan year worth of data?
Let's revisit it in spring of 2015 if we're all here, still here.
Mr. Hager, I'm going to push my button and going to say that's likely not enough time to have enough information. You'll be making decisions based on year one. Your claims, if you're doing it in the middle of 2015, you still are going to have the cycle period of the 6 months prior for the October of 2015 renewal process. So maybe it's the better part of valor to have at least 18 or 24 months experience when you go through the process in order to be able to have and create a framework for evaluation, or just put it on your schedule to do that, so that you'll have the ability to make meaningful change for the offering year for 16. I'm concerned that I'm concerned that if you do it too short, you're not going to have enough participation in the plans in year one to make any comparison meaningful. So I would say that if you decide to make it 2 years, you should at least have significant amount of membership and experience under your belt.
I think if you wait till, I think you can always revisit it in spring of 2015 and always decide at that time that you're not going to change anything. You can revisit it a year later. So just because you revisit something doesn't assume you're going to change it. It just means that you're not going to fly blind when you have some information. So I guess I would stick to the spring of 2015 with the obvious statement that one of the possibilities there will simply be just to leave things as they are.
For the record, Dr. Roberts, I agree with Dr. Ash-Jackson. We have to have enough time and enough claims experience before we revisit things such as the certification standards. I really think that it's premature to go in the spring of 15. I would move to support Dr. Ash-Jackson's recommendation that we wait 24 months from the opening of the exchange before we revisit the standards.
Okay. Actually, I'm going to ask our Deputy AG to help me, because we've had a motion from Dr. Klein to put a limit. Didn't you move to amend, Dr. Klein? I just want to make sure procedurally that we're doing this correctly.
I did make that motion, so if you disagree, you can vote it down, I guess.
Okay, but
Yes, but there's no second now that I think about it.
If there's no second, then it would die, but if
Okay.
it's been motioned and was seconded, then you could just vote on it and determine what happens with it that way.
okay, thank you.
For the record, John Hager, I will say that the staff, is committed to ongoing monitoring of open enrollment and the progress that the exchange is making, and reviewing the plans. I do agree that it may be difficult to provide a proper analysis with one plan year of data, especially because of the risk and unknowns involved in that first year. I would not be surprised if there would potentially be an increase in the average cost of coverage, and then a decrease after that because people understand better what they're pricing. However, on the flip side of that, if you were to wait 2 years, so you have 14 and 15 under your belt, so you make a decision in 2016, at that point it's really too late to affect change for 2017, so at that point you're really looking at making changes for calendar year 2018. So again, staff is committed to ongoing monitoring of all of the policies that the board makes, and determining if there's any issues. It will be difficult to do any kind of review earlier than after 2 years, but if we do that review after 2 years, then we're pushing any changes subsequent to that till probably calendar year 2018. So we need to make sure we get both sides of that.
Dr. Ahern?
John, are you saying then that there won't be any data that would make a 1 year revisit meaningful? Is that what I'm hearing you say?
For the record, John Hager, there could be data that's meaningful. What I would expect to see, so the committee and the board have discussed not providing a standard plan for at least the first year. We could get data as early as the first open enrollment from enrollees determining that this was very confusing and maybe we do need to create some standardization. And so you could do that based on open enrollment surveys of the population. As far as a determination on whether or not to go from a free market facilitator model to an active purchaser model, to do an active purchaser model, you really need to know what the rates look like in your market, and that data will definitely not be available for 2 years.
You have to know whether or not the risk has been evenly distributed among the plans, what the market looks like. Some plans that may be participating in both exchanges might want to leave one. I think there's a lot or go into another one, if so I think it would be a lot better if you had that information, but it certainly would behoove you to do surveys on how well the plans are understood and how well the whole navigator model worked.
Larry Mathias, I think my greatest concern is that I don't think that the population that is likely to be part of this experiment in 2014 is going to be a very representative sample of what happens when and if the exchange approach becomes the general one by which health insurance is accessed. And so it seems to me that what we want to make sure is that we've gotten the best take on the information before 2016, which looks to me like it's going to be the breakout year, that all of those people who are covered by plans that are being grandfathered, waiting to see what kind of world this is going to be, it's quite likely that by that point we're going to see a major break in terms of people who will be searching for insurance, maybe for the first time individually, or larger groups looking for it. So it does seem to me that we want as much information out of the first 2 years as possible to guide us, especially on the issue of plans that we certify and the process that we're going to go through for the 2016 and 2017 cycle, when I expect we will see a significant expansion of the of people that are involved. So I think that you would want as a relook at the basic policy issues sometime before you start the 2016 open period. Sometime that fall would make the most sense to me. You won't have all the information on pricing, but I would submit you won't have that until many more Nevadans that are going to come into it in 2014 are in it. That it's going to be not a real marketplace. It's going to be a perverse little market for a while, and as such is only going to give you indicators of where this process may lead you down the road. But we need to study those indicators and make sure that the policies we will have adopted for 2014 and 2015 don't bias the process or bias the market so much that when a much larger group of Nevadans seek information through it, that then we're scrambling to try to fix what could have been anticipated and done through advanced work. So that'd be my concern. I don't have a timeline, but it seems to me that makes the most sense.
Dan Ahern for the record. I don't see why we shouldn't look at things earlier than later because of the vast number of unknowns that you've just well outlined, Larry. I would be more in favor of revisiting. I don't think Dr. Klein, not to speak for him, is suggesting things change, but just take a look at where things are earlier than later. We don't know what's going to happen. So that's where I mean,
I'm not, to reiterate what I said before, revisiting something doesn't mean you're going to change it. It just means you look at it. And as it stands, and if Larry wants to do fall of 2015, that's completely fine with me. Another few months doesn't matter. But it's hard for me to see how anybody can be opposed to looking at something. If we're looking at something in 2016, now we're in 2012, we're talking about basically closing our eyes for 3.5 years and saying, okay, in 3.5 years we'll look at this again. Right now we'll just keep doing what we're doing. It's hard for me to imagine that anybody could be opposed to opening your eyes and looking at something and saying, yep, it's working, revisit this in a year or two, or nope, it's not working, we need to change it. It's hard for me to see why anybody would be opposed to that. And as Mr. Hager has said, regardless of what we say, his staff is obviously looking at this every week, every month to see how it's working out.
Do we have any other discussion?
Madam Chair, I have a comment.
Yes.
This is Steve Woodley. I think part of this discussion also involves, maybe it's predicated on understanding what the board and the exchange expectations are with respect to the length of certification for carriers. So if we're going to evaluate over a date certain period of time, we would almost need to know when they come in and are certified, are we going to have a lock-in period of 24 months? Otherwise, if we don't have a defined period of time by which they're certified and then they have to become recertified or move in and out of the exchange, I could see where a carrier could be on for a year, pull out, upset the accumulation of claim status. So we almost need to know where we're going to be going with respect to when the request for application goes out. Will carriers be locked in for a 24-month period? And if they don't choose on the front end, then the next opportunity will be at that point. But I also agree with the comments made that I think we can certainly look at this sooner rather than later. It's very prudent to do so, whether any changes are made. I just think it preserves flexibility for the board and the exchange.
Any other comments from committee members? All right, we do have a motion from Dr. Roberts. Do I hear a second?
I'll second.
Now, this was from Dr. Roberts that we, okay. Dr. Roberts, do you want to repeat your motion, please?
Yes, I was going to move that the, redirect that the certification processes be reviewed after 2 years of claims data has been received.
All right. Mr. Woodley, did you want to continue with your second?
No, I'll withdraw. I was going for an earlier period of time. I thought he was echoing Dr. Klein's
No, and
comments.
that's why I asked for the clarification. All right.
Chair Campbell,
Yes.
Can I split the difference here and say that we look at this in the fall of 2000, and we look at this at a time in 2015 so that changes can be made for calendar year 2016.
Dr. Klein, let me see if Dr. Roberts' motion dies for a lack of a second, and then we'll look for another motion on this. Do I hear a second? All right. That motion dies for lack of a second. And Dr. Klein, did you want to make a suggestion?
Yes, King Solomon's splitting the baby in half. If we can look at this maybe towards the at a period in 2015, at a period in calendar year 2015, so that sufficient time is allowed to make changes for the 2016 benefit year. If that makes any sense. If not, John will fix it for me.
For the record, John Hager, unfortunately that will be extremely difficult to meet that requirement. If you look at what we're doing right now in the fall of 2012, we are about 15 months out from the calendar year. We're less than a year out from the open enrollment for 2014. The requirements for the exchange, inputting information in the exchange, and then the Division of Insurance certification process, we're looking at, I believe, February, March, starting to receive applications for certification. So that would leave you for 2016, basically January, February to make those decisions. However, you won't have the claims run out from 2014 yet. It takes at least 3 months to get a decent claims run out. And even then, you don't get all the claims in there, but you get a majority of them. So any information on claims run out and rates would not be available. Now, as far as the process,
so if I go back to sorry to interrupt you. So if I go back to my original motion of spring of 2015. Sorry to interrupt you, John. We're basically looking for changes in 2017 to have an effect for okay.
Yes.
So maybe I go back to my original motion then of spring of 2015. Whatever works for people.
All right, we have another motion on the floor. Is there a second to Dr. Klein's motion?
Dan Ahern, I'll second.
Okay, looks like we have a second and a third on that. Any other discussion on this agenda item? Then I will call for the vote. All those in favor?
Aye.
Aye.
Any opposed?
Aye.
Nay.
Opposed, nay. Sorry, I'm not used to disagreeing.
That's okay. All right, so let me do a head count here. The ayes have it. There are 2 nays to the motion. Okay, John, let's go on to the certification processes.
the certification process requirements are laid out in Section 155.10.10 of the regulation. On April 12th, the board approved the committee's recommendation to allow the Division of Insurance to conduct rate review for qualified health plans offered in the exchange. The Division of Insurance indicated that it could leverage its current rate review process to ensure the requirements of the exchange are met. As long as the requirements of the exchange remain minimalistic, the Division of Insurance indicated it is best positioned to conduct the full certification of QHPs on behalf of the exchange. The certification process would be aligned as much as possible with the rate review process. Staff will work with the Division of Insurance to determine appropriate processes and timelines for certification. The recommendation is to allow the Division of Insurance on behalf of the exchange to certify health plans as qualified health plans offered on the exchange.
Mr. Hager, I need some clarification of what minimalistic means.
I suppose it's as vague as the term soon. I suppose that is really up to the Division of Insurance. If the requirements that the exchange imposes become too burdensome for the Division of Insurance to be able to efficiently certify plans, then it could disrupt that agreement with the Division of Insurance. As of this moment, the requirements that the committee has recommended and the other committees have recommended to the board and have been approved by the board are very minimalistic. They don't add significant requirements to the Division of Insurance. The Division of Insurance is perfectly willing to, from my understanding, and maybe Mr. Plain can speak up on this, or he can just nod his head, but my understanding is as long as we are pretty close to what the Affordable Care Act requires, then they can go ahead and do this for us. If we start piling on restriction after restriction after restriction, then that could make it difficult for them to leverage their current processes, and they may say, you know what, we don't want to do this. Again, the way we're headed, it would take quite a bit of extra regulation and requirements at this point to I think, upset the apple cart.
Not arguing that, it's just that I'm given to understand that the Division of Insurance has outsourced its rate review process to an entity that meets all the standards of the feds, and that's at least a 45-day process. So just want to understand that how that all fits in and what other decisions the Division of Insurance is going to be making on the rate review process that would potentially impact the exchange. So, for instance, I understand that you can, I know the exchange is going to have an open enrollment once a year, but my assumption is that as people become eligible and lose their insurance, they can move in and out as they need to. So will there be rules about one rate good for an entire year when you do the product, or is it going to be that it trends with time? So those are the sorts of questions that might make it onerous for the Division of Insurance. So that's why I'm just curious what minimalistic means.
So to your example about the review of rates and how long they're good for, there is either a law or a regulation in Nevada that states that an insurance carrier can raise rates for a small employer every 6 months if it needs to. That process follows under the rate review process that the Division of Insurance does. The Affordable Care Act requires, at least for exchanges, and I'm not sure if it applies to all plans, but that the rates must be set for a full year. The Division of Insurance currently does the rate review for plans on the market, and those plans can be updated as much as monthly, but once those plans are updated, they are good for the full year, or I guess for 6 months in certain circumstances. For the individual market, I believe it's annual. So the Division of Insurance is capable of managing what's currently in law, and the Affordable Care Act in this case actually makes it easier because they would be in place for a full year rather than 6 months. That's obviously one example. To speak to the concerns that you kind of obliquely raised about capacity, we are concerned about capacity. The exchanges, as well as I believe the Division of Insurance is. I try not to speak for them, but we had lots of conversations. There will be capacity issues across the country about certification and rate review, and the organizations that currently do those processes. So it's, again, a national concern. I believe the organizations that do the rate review process are probably ramping up to be able to handle that. The increased demand for rate review processes. The rate review and certification process will happen every year, but the first one, there's going to be so many changes to plans that is pretty much like starting from scratch for all of these plans, because they're all, for the most part, brand new. Even the grandfather plans that can maintain some of their similarities will still have additional requirements that will have to be reviewed. So because of that, we end up with a lot of demand for rate review and certification processes. Again, we are all concerned about that, and that I'm sure there's going to be quite a few conversations with that at the Division of Insurance, and we'll continue to maintain our dialogue with them. After we get past that first year, while there will be continual upgrades to the market like there are today, many of the plans will be able to continue forward without an additional full rate review. It would be a modified review, modified certification, similar to what they do today. So the capacity issues are our biggest concern, again, over this next winter, spring, summer. But again, it appears that we would have to make a whole lot of changes and really change the direction of the exchange to make this an issue for the Division of Insurance to be able to do this.
I'm not arguing that they shouldn't do it. I just wanted to understand what minimalistic was, that if it got more complex or a lot more insurers in the market, that it's more about the timeline. Year one, you said we're going to be looking at rates in February and March. To Dr. Klein's point, if we're going to be looking at stuff earlier, that same March, February rate review, because of claims completion on year one, wouldn't be, everybody's going to put a different IBNR on that number, and so it's going to be very difficult to try to figure out how the experience shakes out. That's all.
There's no doubt that this will be difficult for everybody involved. I guess an example of what would become less than minimalistic, or it wouldn't be just this, but if the exchange were to impose additional network adequacy standards that are different from the rest of the market, then they are looking at exchange plans much differently from other plan requirements. If we put let's say a cap on the smoking rating band, it's currently 1 to 1.5. I think California is looking at either eliminating it or changing it to 1 to 1.2. I don't know if that's just for the exchange or the entire market, but again, if they're looking at that differently for the exchange than they are for the rest of the market, that could add complexity. So anytime we add something that is separate or more restrictive than what the Affordable Care Act requires of the entire market, that could make it more difficult.
Chair Campbell, thank you. Without making this difficult, since we have 11 of these criteria to go through, I would like to make a motion that all 11 of these, whatever A through K, be looked at in spring of 2015, which I would remind everybody is 2.5 years from now. And again, emphasize, which I've tried to emphasize multiple times, that doesn't mean you change things. It just means that you pick your head out of the sand after 2.5 years and say, well, what have we accomplished? Understanding all the caveats that Dr. Ash-Jackson and Dr. Roberts have stated, it seems like at 2.5 years from now, we'll be worth looking at these and saying, well, we got a year under our belt. Is this working? So I would move that for A through K, we review all of these in spring of 2015, again, with the caveats mentioned, and again, with a statement that they don't necessarily change. We just look at them and say how they're working out.
Second.
Who is the second? I could hear that.
It's Vicki Mayville.
Thank you, Ms. Mayville. All right. Has the committee heard the motion in the second? Is there any discussion? All right. I'll call for the vote. All those in favor?
Aye.
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 Are there any opposed? All right. Dr. Klein, you have a unanimous approval of that motion.
I'm going to write this date down on my calendar.
All
Thank
right,
you.
that's good. We can give you a star there. I have just a basic question, and Mr. Plain, I don't mean to put you on the spot, but since your division of insurance, maybe you can help walk us through this process a little bit to the extent that you know the answers. We're talking February and March starting to accept applications for the qualified health plans. How is that certification process going to move? I mean, keep it at a 50,000-foot level if you need to, but I mean, we're talking 3.5 months from now.
For the record, Adam Plain, Nevada Division of Insurance. I think to speak to your question in terms of just general timeline, if a plan is offered in open enrollment, so 10/1/13, we're still determining with the exchange, Xerox and Choice Partners, how long they need for a submission to be how the advance time they need for a product to be submitted prior to being available on the exchange portal. So if we look at just a ballpark figure, 60 days, we're looking at approximately August 1st of 2013. Prior to that, if we have the plan certification process of 45 to 60 days, then we'd be in say June 15th through June 1st of 2013. Prior to that, an insurer would need a certain amount of time to develop a product, test it internally, both mathematically and systems-wise, before they submit it to the division for certification. I'm not an expert on how long that would take, but if we look at 60 to 90 days, in the ballpark at least, from June 1st, that takes us back 2 to 3 months. So April 1st, March 1st of 13, somewhere in that range. So just a conservative estimate, using those ballpark off-the-wall figures, March 1st of 13 would probably be when we're looking at having a solid plan certification, plan management program in place for an insurer to start developing a product and have it be on a timetable that it can meet the October 1st, 13 deadline for sale.
Just that plan certification management system, is that something that you're developing right now, or is it in place and because you're using it some other place and you just move it over to the exchange product, or how does that work?
There are some similar processes in place with various aspects of plan certification and plan management. One aspect is the rate review portion. The Division of Insurance currently does that for all products already. For, say, like network adequacy, we have network adequacy provisions in Nevada applied to health maintenance organizations. So that's a process that, to some degree, can be transferred over to PPO, POS, and other types of products. Some of it is going to be from the ground up, and those are processes that we're working to develop and trying to get information from the federal government, HHS and SOCIO, as to what exactly they're looking for and how we're going to build it from there.
Thank you. Any questions of committee members to Mr. Plain?
Sure, Madam Chair. This is Steve Woodley. I have a question. And I don't know if this goes to John or to you, Adam. My question is, I want to know the information flow. So is the exchange, in conjunction with this committee, going to be responsible for drafting the request for application to the carriers, and then it floats to the insurance division to approve it, and that's what goes out to the market? Because I'm thinking, if carriers need to know what products they're going to develop by March, that presumes that you have to know which carriers are approved and certified to offer on the exchange, which means there has to be some sort of process by which an application is floated, submitted, reviewed, approved, and then notified to the carrier. So is the exchange and the committee developing that request for application floating to you guys, or is the division doing it and floating it back to us for review?
Mr. Plain, before you answer, we've got somebody on the telephone that we're getting a lot of background noise. So anyone that's joining on telephone, would you mind muting your phone, please? Thank you. Mr. Plain?
Again, for the record, Adam Plain, Nevada Division of Insurance. I'm not sure I know the exact answer to that. If you're speaking in regards to like the NCQA or URAC certification process, then I really don't know.
For the record, John Hager. So keep in mind that this is the free market facilitator model that we've implemented. Therefore, it's not necessary that the exchange know all of the carriers that are willing to be qualified health plans until the onboarding process of the qualified health plans in the summer. Now, that's not to say we don't really want to know, so we have an idea that our policies are tantalizing for the carriers, right? They want to come and participate. So we certainly want to know that they're going to participate so that we can adjust policy as necessary. But unlike, say, California or Washington, where they are submitting an application to become a QHP, and then and if they don't submit the application, then they can't be a QHP. I had not foreseen that that process. To me, and this is, I guess, for discussion, but it would seem to me that a carrier that wants to be a QHP could simply provide that as a one-liner on their application to the Division of Insurance. Oh yeah, we want to be a QHP and offer it on the exchange. So I don't see a large application process that requires extra administration and stuff like that.
Nevertheless, it's a huge amount of work for the division, who has to review likely either amendments to or new evidence of coverages for all the new plans that meet the criteria, and new standards of benefits, new pharmacy riders, all sorts of things that have to go along before they can do the rate review, or at the same time they do the rate review for those plans. The rules around what can be offered inside and the outside of the exchange in a small group around the metal percentages, all those plans have to be tested by the plans, and I don't know whether or not the division's going to do that. So, I mean, my assumption is the plan, it's going to say, yes, we want to participate, and then we all have to go through a number of hoops in each of the areas in order to be able to make sure that the division has the information they need to be able to say, this particular benefit plan meets criteria, and here's the certification you have of a qualified plan. So it is a lot of work on their part and on all of the carriers' parts.
And I think now that I've had a little bit of a chance to ruminate on it, just to clarify, when it comes to a qualified health plan, the individual product, the product has to be certified as a QHP, but the issuer has to have a certification as well. And that issuer certification is what we're talking about with the URAC or the NCQA accreditation, and I assume kind of what you're getting at with the lead up prior to March 1st. And I don't know the prevalence of those accreditations in the industry currently. If I were to just make some gross assumptions that a large health insurer is already in possession of one of those two accreditations, then they would be all set from a insurer standpoint to go ahead and offer. An insurer coming from out of state or a newly formed insurer who wished to offer a QHP but was not URAC or NCQA accredited would have a regulatory hurdle to jump over, but that would be in addition to any other, say, insurer formulation hurdles or admittance to the state of Nevada in terms of financial responsibility and experience and trustworthiness of officers, and so it would almost be a process where they'd have to, a newly admitted insurer wishing to offer a QHP in Nevada would be well served going through that accreditation process in parallel with their admittance for a certificate of authority, as opposed to getting the C of A lined up, then waiting for the accreditation and having it be an extended process.
Yeah, there's. I don't know. I guess I have a lot of questions here on it, but I'm not sure that they're directly on point with the processes on it. I would imagine, though, that when people want to enter into this market, they're going to be asking both the Division of Insurance and the Health Insurance Exchange, where's my application form? To some extent. I don't think that, I just would like to throw that out as a thought, because usually when you're applying for something new, you can go and click on someplace and it helps walk you through an instruction process.
Yeah, maybe if you don't have an application, you should still think about a checklist or something with an explanation that basically, instead of just handing them these 11 items the way it's written, be able to say, be prepared to have the following in place, and then here's this reference. Be prepared to have this, and here's that reference. And then some explanation of the timeline that the expectation is, the timeline about when you need the information, as well as the DOI timeline for the ability to get it complete.
For the record, John Hager. So first thing I think I need to point out is the Division of Insurance are the experts in this. They really do this process. Now it's rate review, but they look at other things, financial solvency, network adequacy, et cetera. The Division of Insurance is working on the process, and I imagine that there will be some type of application or something, whatever we have today will be adjusted to make sure it accounts for all the requirements in 2014. This recommendation was simply to allow the Division of Insurance to certify plans as QHPs on behalf of the exchange. And again, that last sentence on that paragraph, staff will work with the Division of Insurance to determine appropriate processes and timelines for certification. So this will really assist us in submitting the blueprint to CSIO for the exchange, saying, yeah, we got the entity in place, they're going to do it. Obviously, things could change if necessary. Again, staff is monitoring all of this on an ongoing basis, and things change all the time. But this is simply to allow the Division of Insurance to do the process. We will continue to work with the Division of Insurance to make sure that the process itself is adequate for the needs of both the Division of Insurance, the market as a whole, and the exchange.
Well, I think if there aren't any objections, I'm going to move and ask for a motion on that recommendation, knowing that all of these recommendations have the spring 2015 review within them. And then I think some of our other questions may get addressed as we move through these other bullet points.
Madam Chairperson, I move that the Division of Insurance work on behalf of the exchange to certify health plans as QHBs to be offered on the small group and the individual exchange.
And I'll second.
Second, Mr. Roberts.
All right, we have a motion and second. Pardon me? Mr. Mathias for the second. Okay. All those in favor?
Aye.
Aye.
Any opposed? Thank you very much. Okay, moving on to rate and benefit information.
Section 155.1020 of the regulation requires several things regarding rate and benefit information. A justification of rate increases. It has to be posted on the website of the carrier. The exchange must review it, or an entity must review it for the exchange, in this case We've discussed in the past that the Division of Insurance will conduct the rate review process. These requirements are all aligned with the requirements of the Division of Insurance. Again, to do the rate review process, staff will work with the Division of Insurance to ensure all requirements are captured in that process. This was basically provided to make sure that people didn't think we were trying to skip anything in the regulation, but there's no recommendation required for this item.
Do we have any questions from committee members to Mr. Hager on this particular item? Hearing none, let's move on to transparency.
Section 155-1040 indicates that the exchange must collect information related to coverage transparency. The plans and the exchange must use plain language, and that there must be transparency of cost-sharing information. The carrier must provide to the exchange and the Division of Insurance certain information as required pursuant to Section 156-220, including cost-sharing information. The exchange web portal will use this information to assist individuals and employees making enrollment decisions. So again, there's no recommendation required for this. This is more administrative. We will provide all the information that we get from the plans on our web portal. There will be a lot of requirements of the carriers to make sure that that information is available. I don't remember if, I know it wasn't this committee, I think it was the Consumer Assistance Committee that had the web portal demonstration, and the board had the web portal demonstration, and most of these items were in that demonstration.
John, Dan Ahern for the record. Is plain language, is that a term of art, or is it further defined? Because what's plain for me...
Yeah, I believe it's defined, but still leaves a lot of wiggle room. We will make sure we'll make sure that it complies with the law that's defined. It defines plain language. In some cases, it may be is it subjective? I get them subjective, objective. It might be open for interpretation. We'll do our best to make sure that it is plain language.
For the population that this is going out to is where I'm going. Fourth and fifth grade education usually is the health literacy standard.
Yeah, Ms. Larry, I think that these provisions are going to be the key, much more so than prices, because the prices don't necessarily tell you if you're getting what you think you're getting. And so the transparency, I think the use of plain language is using language that insurers have not usually used. It would be my interpretation of that. And I think that's the way the feds have approached it, that there needs to be clearer language than is normally used in insurance contracting activities. So I think that this is going to be one of those areas nationwide in all of these experiments that has the most potential benefit for really making the purchaser, the individual or the small group, a fully knowledgeable consumer.
Madam Chairwoman, there is a standard out there now, a standard summary of benefits that have to be prepared for every plan that talks about cost sharing for very specific criteria and procedures. That may be a place where the exchange wants to begin with regard to plain evaluation. It was designed as part of the Affordable Care Act, and it's standard to accompany the health plan summary of benefits as a minimum.
Do we have any questions or comments from Las Vegas? Hearing none, and staff is not recommending anything on this item. Let's move ahead to accreditation, the timeline.
The regulation indicates the exchange must establish a uniform period following certification of a QHP within which a QHP issuer that is not already accredited must become accredited as required by the regulation, except for multi-state plans, in which case the OPM, the Office of Personnel Management, will establish the accreditation period for multi-state plans. The regulation also requires that each QHP issuer be accredited by an accrediting entity recognized by the U.S. Department of Health and Human Services. At this point, HHS has recognized the National Committee for Quality Assurance, NCQA, and URAC, and the reason URAC's not spelled out is because URAC is simply URAC, as national accrediting entities. Discussions with NCQA and URAC have indicated that accreditation often takes as long as 18 months, sometimes longer. There are further concerns that this timeline may be extended due to the large number of carriers that may need accreditation and the changes to standards required by the Affordable Care Act. While it would be ideal that every carrier have an NCQA or URAC accreditation, staff is concerned that it will be difficult for every carrier to have such accreditation by the first day of open enrollment on October 1st, 2013. Additionally, in the future, new entrants into the market may have difficulty penetrating the market if they are not allowed to offer QHBs because of a 2-year lag in the accreditation process. Therefore, a phased-in approach may be more effective. So the recommendation is to require that a carrier offering a QHP must have either a certification by NCQA, URAC, or another accreditation entity recognized by HHS, or a letter of survey or audit from such an accrediting entity indicating that such a survey or audit has begun and that the completion date will be within 24 months of the date of the letter. A carrier that does not receive accreditation within 24 months of the date of the letter will lose their QHP status following the completion of the plan year in which the deadline occurred. A licensed carrier that does not receive a satisfactory accreditation within the above timeline must be accredited before being allowed to sell QHPs on the exchange. The executive director or the exchange board may make exceptions to this timeline if recommended by NCQA, URAC, or the Commissioner of Insurance. So the idea, we've got a hard deadline of 24 months. We possibly make an exception to this if the board or I approve it, or the executive director approves it, if it's recommended by NCQA, URAC, or the Commissioner of Insurance because of a capacity issue, something like that. It gives us an out to say, all right, this is not, 24 months isn't hard. We can make an adjustment if necessary. It may or may not be on a case-by-case basis. It might only affect one or two carriers, but it might be because of general capacity issues. So that's the idea of that last sentence there.
And open it up for discussion.
Can I clarify? So 24 months from January 1st, 2014? Is that the intention, or from the plan's first participation in the exchange? So when does the 24-month period begin?
The way we wrote this, we envisioned it being 24 months from the date of the letter, which we would expect that to be, you'd either expect to have an accreditation or that letter of survey in hand when requesting to be a qualified health plan. So at a minimum, it would have to, the Division of Insurance would not be able to certify a carrier as, would not be able to certify QHPs for carriers that do not have that letter in hand. Again, that letter is just to start the process, but in the case where the timelines we're talking about, April timeline, they would have to have that accreditation completed by April of 2015.
Yeah, I just think it's important that we nail down what that 2-year period is from the date of the letter, because if you have someone get a letter, for the sake of argument, on January 1st, 2014, then they've participated for 2 years in the exchange, and their certification date deadline is December 31st, 2016. So is it from the time when you declare that you want to be in? When is it from October? Being in the middle of one of these now, I have one of these letters. So I would say that it's important that you nail it down if your intention is to be in the exchange, and and open enrollment, for the sake of argument, is October of 2013, and the certification's going to be completed by the DOI at some point, then they have to have, I would say that they have to have that letter in their packet in order to be able to certify that plan for offering. And then same thing for the next year, as they certify the plans that want to be offered in 2015, they have to have that when they certify.
So
Does that make sense? I mean,
it does. So first of all, we would not allow a carrier to begin the onboarding process unless they were a certified QHP, unless they had a certified QHP, which meant that they had a survey in hand that said there's a letter of survey. So in that case, if we're talking about a July or August onboarding process, they can't do that process unless they've got that certification complete and the accreditation started to allow them to have a certified QHP. And there is a process at the Division of Insurance that goes through the certification of QHPs. One of those standards or requirements would be that they have a letter of survey saying that they'll have it done within 24 months at that point. So it would be at least a couple months prior to the beginning of open enrollment. Now, the reason I would hesitate to add a hard date is because a carrier could offer a plan in the shop exchange mid-year, because the open enrollment periods, while they're on an annual basis, they might not necessarily be on a calendar year basis. And so if a carrier decides that they want to offer a shop product and they get that process going in early winter or maybe late fall, they could offer a plan, say, in June, potentially, to employers. So the issue is, to be a qualified health plan, to even start the process to get on the exchange, you have to be a qualified health plan. To do that, the carrier has to either be accredited or have that letter of survey in hand.
This is Ron Klein, and I would agree with the comments. I would agree with John's comments. I think the executive director's discretion will be important here in terms of how long it takes the national accrediting bodies to certify these plans. My practice is now 3.5 years into a process of trying to be certified for conscious sedation in our office that the legislature decreed had to occur in 12 months, and we've been working on it diligently from day one. So sometimes these things go slower and that are not in anybody's control.
Would it help to enter in the first sentence, require that prior to starting the onboarding process, a carrier offering a QHP must
either be certified or have.
John, can I ask a clarifying question? So if I'm hearing this correctly, then we are not going to have any kind of conditional certification for carriers who do not already have a letter of survey or already NCQA accredited when they make application to get on the exchange as a QHP. So that's what I just want to make sure of, because it sounds like it's an all or nothing proposition. Either you have NCQA or URAC accreditation on the front end with the letter of survey stipulating same, or you don't, at which time you won't meet the criteria by which the DOI would allow you to get on board on the onboarding process, because I know this is contrary to other states which allow a conditional certification. That's what I'm just trying to figure out where we're going with this.
So we probably should look at, if you have a letter of survey, you are really a conditionally certified QHP because you don't have the accreditation yet. So we're not really making the distinction between conditionally certified and certified, but you have to at least have that letter. And that letter, from my understanding, is not difficult to obtain. It's your intent to engage NCQA or URAC. And maybe Dr. Jackson has some more information on this, but my understanding is the letter is not difficult to obtain. It's completing the certification.
well, you have to complete an application and send them a check, and so it's not that difficult to obtain, but you also put yourself on the schedule from their perspective. So you put yourself on the schedule for survey. I just need to clarify one thing that both URAC and NCQA certify by product and by company, and I find it very difficult to believe that there will be very many HMOs in the exchange at some of the metal levels, because it would be difficult to underwrite those and still offer HMO type coverage. So for the sake of argument, as we go through this process, we have a separate accreditation we have to do for our HMO and a separate accreditation we have to do for our PPO, and in order to be able to have both products certified, many plans just go through and do the HMO product. So I don't know what the exchange's expectations are about having one product certified and not the other product, and being able to offer coverage off of both licenses in the state.
Dr. Klein, or may I ask a question, please?
Please go ahead.
Chair Jack? Yeah. I apologize again for my ignorance. I understand why a company would be certified to show that it's a good corporate player and a good health insurer. I don't understand why each and every plan would have to be certified. That, if you could, somebody could enlighten me.
That is the way that NCQA and URAC have structured their certifications. So if you go on the websites of either company and you look up, they will, for the sake of argument, say that NCQA has certified HMO or certified Medicare Advantage for this company or certified PPO for this company. It doesn't list all the products unless each of the products has had a survey and individual work on that product has taken place. That's their rules, not my rules.
Dr. Jackson, so are they certifying each individual plan, or are they certifying a product line?
A product line.
So they would say, if you were seeking certification as part of Hometown Health for my HMO product.
So Hometown Health is Hometown Health Plan, which is the HMO, and Hometown Health Providers. We have a certification and process for both entities, both companies. That is what we had to do to be able to be certified to offer the PPO product on the exchange.
Ron Klein again. Could we, and this might be the wrong thing to do, but could we simply say as an exchange that we're content with a company being certified as opposed to each and every plan? Would that be an appropriate middle ground?
The Affordable Care Act requires that the carrier be certified. It doesn't specifically say individual product line. However, the Affordable Care Act also requires, or at least the regulations require, that the carrier be accredited with NCQA or URAC, and so therefore the accreditation must follow the NCQA or URAC standards. You would want to, if you wanted to separate that, assuming that NCQA or URAC could do that, the issue you might run into is one of the things that NCQA and URAC look at is network adequacy, and HMOs and PPOs have different networks. There are other things that are different between the various plans, and so it is probably appropriate to continue or allow NCQA and URAC to continue as they currently do their business, and simply we require that the carrier have the certification. It probably does need to be on the product line.
I would agree, especially since when we were talking about the number of plans that each company could offer on each level, there was a distinction made about so many plans per carrier, So my assumption would be that if someone wanted to offer five plans under Platinum for their HMO and 5 plans under Platinum for their PPO, they could do that if they were sitting at different companies. And I know in the state there are, I believe that HPN is separate from Sierra Health Network. And so just knowing that and knowing how we operate, I can't speak for the other carriers. I know that Aetna PPO is written on different from Aetna HMO. So if you're going to have that, I mean, I think you have to have a product by product certification.
So are you saying that if a carrier offers 5 plans in 4 tiers, so 20 plans, they have to have each of those 20 plans separately certified? Is that, am I understanding correctly?
No, they have to have the umbrella product certified. So the product, if the product is PPO, then they have to have the PPO certified under whatever entity they offer it. And if it's the HMO, then they have to have the HMO certified under whatever entity they offer it.
Okay.
That's pretty much what the expectation is.
Could you
And I've
just
got
certify?
people shaking their heads here, so.
Well, so could you just certify a carrier for all of its exchange plans, meaning one certification, or would that not work either?
It doesn't meet the intent of the law, I think.
For the record, John Hager, I think, again, the NCQA or URAC, it appears, accredit an entity by product line. I don't know if there is a carrier, a single licensed carrier that offers both PPO and HMO under the same entity, but if there were such a carrier, URAC and NCQA would require accreditation for both the PPO product line, which could have 100 different products in it, 100 different PPO products, and then the HMO product line, which would have potentially another 100 HMOs in it. So it doesn't mean that you'd have to accredit each plan, but you would have to accredit each product line. And what I would say in this one is to simply, well, we'll go back and discuss it with the Division of Insurance to see if there are any carriers that offer multiple product lines under one licensed plan. But assuming that there is not, then this recommendation would be fine because they would be separate licensed carriers. So each carrier would have to have that certificate, the accreditation.
Not to make it more complicated, but if the Division of Insurance or the legislature worked through offering co-insurance on the HMO, then you could potentially have just the HMO accredited because you'd be able to create cost sharing that would work with regard to the multiple levels in the exchange. And I thought there was some working on that, as I understood, from the Division of Insurance.
We have Mr. Plain coming forward. He may be able to clarify some of this for us.
Thank you, Chairwoman. Adam Plain, Nevada Division of Insurance, for the record. I think to speak to some of the questions, using a somewhat crude comparison, if General Motors, the old General Motors, were an insurer, their Chevy products and their Pontiac products would be considered different companies. And so Chevrolet and Pontiac would each have to have a URAC or NCQA accreditation or certification. Having a General Motors certification wouldn't work. And so for an insurer, it would be similar. A large holding group wouldn't be the certified entity, it would be the license holder, each individual small company.
So going to your example, General Motors would have to get the license as the overall owner, and then the Pontiac and Chevrolet individually would have to get certified as well? Or are we just talking about?
No, it would be a scenario where, for example, Chevrolet would need to get the certification, but they wouldn't need one for the Cavalier and the Trailblazer and the individual models under that label. So you wouldn't need a certification for each HMO or PPO product, but the insurer whose name was on the license would get certified for all of their individual products.
This is Ron Klein. May I ask a question?
Sure.
I'm having trouble understanding product line, the term product line. So a product line is an HMO, a PPO, a Medicare Advantage plan, a Medicaid plan. Those are product lines, and as opposed to, that's a product line as opposed to the plans underneath them?
For the record, John Hager, so a product line is all of the HMOs under a carrier. So multiple plans that are HMOs. There's an HMO product line for a carrier, or there's an HMO product line for a PPO. It doesn't mean it's one PPO. It means it could be 100 different PPOs. Different PPO plans are in that PPO product line.
So Medicare HMO is under the Medicare product line or the HMO product line? It's a Cadillac with a Chevy engine. So what do we?
For the record, John Hager, I'm not sure. However, on the Medicare side, we can't offer Medicare products, so I'm not.
Sure, no, I understand that. I'm just trying to understand the term product line. It's not an obvious term to me when you say HMO and PPO. So I'm trying to understand as distinct from plans, which are not product lines. So I'm trying to understand what a product line is.
So an HMO,
and maybe I'm the only one confused.
You could have an HMO that has a $200 deductible and another HMO that has a $500 deductible. Those are individual HMO plans within a company's HMO product line. So they would both be part of the same product line, but they'd be separate plans because they have different cost sharing, or they have certain benefits are covered and certain benefits aren't.
So when you have for the sake of argument, if you have we calling it a product line, we have a specific document that governs the health plan's responsibility with regard to the HMO product. And that's accompanied by different benefit levels called summary of benefits based on what the employer wants to purchase. And each one of those plans is priced according to the benefits that the employer has purchased. So because it's a uniform document that covers all of it in that evidence of coverage, and the company that manages it includes all of its HMOs under one entity, that we call that a product line. Similar with the PPO, it's governed by one evidence of coverage document with multiple levels of benefit. So that's the difference. It's basically how the company's structured and what documents govern the way that we deal with our members and the way that the Department of Insurance has licensed us to operate. The Medicare Advantage plans are not available for commercial employers or individuals to purchase, so that's considered, at least in our company, a separate product line, although it may be included for financial reasons under one of the other companies. It depends how the company's decided to structure its financials as to whether or not it's in a different company, but it doesn't impact any of the commercial products.
All right, I have a question for Mr. Hager. How did we come up with the 24-month timeline? Did you just think that is that statutory or in the ACA or?
For the record, John Hager, so we've had some initial discussions with NCQA in URAC. They indicated that they expect it to take 18 months, but because of the many number of carriers that will need to be accredited, I don't remember if it was them or somebody else recommended 24 months, simply adding a little bit on to that 18-month period. It seemed to make sense.
Okay. I mean, I have no objections to the recommendation on it, but I think when we start getting into some things like this might be one of those policies that we need to look at as a regulation, so we have more guidance on it.
Madam Chairperson, there's a general look-back period for performance from the time that for, at least for NCQA, it used to be 3 years, and I understand they have a new accreditation process, during which time policies and procedures have to be in effect, and then they evaluate compliance for that time period. So I don't know how long the look-back period is on the new exchange product. On the URAC side, you need a certain amount of time to actually build the infrastructure and put your policies and procedures and staffing in place. And you have to be compliant from the time you send in your application, your final application, for them to do a review. So it's slightly different than the NCQA is, but it generally takes 15 to 24 months to actually make all the changes that you need to make. Sometimes there are new systems that have to be implemented. You may have to re-credential your entire network. It's a large undertaking.
Madam Chair, I think the operative term or the important term here will be that the executive director has discretion to waive that, which if what is thought to be 18 months turns out to be 36 months because the backlog, then a reasonable executive director will take that into consideration. So I'm comfortable with it as it sits, again, knowing that we'll look at it in spring of 2015 and giving Mr. Hager the discretion to waive that requirement if things get out of hand in terms of the certification process.
Would you like to make a motion?
I would move that we adopt, what is this, number E, subpoint E, as per Mr. Hager's criteria, or the staff's criteria, if that's the correct way to stay at that.
Okay. All right. Is there a second? A discussion?
Second.
Okay, we have a motion and second on the floor. Any discussion?
Yes, Madam Chair. This is Steve Woodley. I'd like to bring the discussion full circle around to fit in with Dr. Klein's motion, in that John Hager's original suggestion to amend the recommendation to, on the front end of the sentence, say, prior to commencement of the onboarding process, require that a carrier offering a QHP must have either 1 or 2 on page 5. I thought that was a really good suggestion, and I think it helps remove ambiguity and it puts it in context. So if it could be amended, the recommendation amended to reflect that, and then the vote taken, I think that would be helpful.
I'll accept that as an amendment.
Okay. Mr. Mathias, did you second? Do you accept that amendment?
Yes, I do.
And then I think Mr. Hager has a comment as well before we vote.
Dr. Jackson, you indicated that a carrier could have an HMO and a Medicare Advantage product line in one licensed carrier, and the Medicare Advantage plan could be accredited, but the HMO wouldn't necessarily be accredited. Is that
Correct.
so? Then one additional recommendation for this would be to with the verbiage you just said, prior to commencing the onboarding process, require that a carrier offering a QHP must have, or we'll work on this afterwards, but have a certification for their product line.
For their commercial. Do you want to say commercial or product line, or whatever you want to say?
Something like that. We can make it work before it goes to the board, but I think it might make sense to change it from carrier to the product line or to the commercial product grouping or something like that.
I'd also ask that you put in some sort of definition for onboarding process and timeline, because it's all been explained to us here, but it's not transparent as to what that means. So that's my amendment, that there be a definition or explanation of the timeline and the onboarding process.
And that we change it to a product line rather than a carrier.
And then we change it to a product line.
John.
Dr. Klein? I'm sorry, Dr. Ahern.
Sorry to prolong this, but I just wonder what happens if somebody loses accreditation. What happens to the folks who are insured under that plan?
I think that's covered later in the decertification.
Dr. Klein, do you accept those amendments made by Dr. Ash Jackson?
I do.
And Mr. Mathias?
Yes, I do.
Okay. I think have we concluded the amendments and edits? Then I will call for the vote. All those in favor?
Aye. Aye.
Any opposed? Motion carries. Thank you. Let's move on to network adequacy.
Regulation indicates that the exchange must ensure that the provider network for each QHP meets the standards specified in the regulation. Currently, the state of Nevada applies standards to HMOs, but does not have network adequacy standards for other types of plans. The Department of Health and Human Services Division of Health currently oversees network adequacy standards. The Division of Insurance has indicated that applying network adequacy standards only to QHPs could create adverse selection issues and therefore should be applied. Therefore, such standards should be applied market-wide. Staff is working with the Division of Health and Division of Insurance to create appropriate market-wide standards. The recommendation is that the exchange adopt the network adequacy standards that are adopted by the state for the entire market. Of course, we don't know what those are yet, but it would seem to me that if those are implemented by the Division of Insurance for the entire market, they should be adequate. I guess the question for the committee would be, is it necessary to apply additional standards on top of what the Division of Insurance may request of the legislature?
Larry Mathias, the problem is, of course, we don't know what those standards are going to be. So I think it is correct that they should be system-wide, statewide. But the problem is the test of whether or not those are adequate. And the reason this is such an important issue is that it has significant consequences for individual consumers and individual patients. That if a plan has an inadequate network for a particularly expensive service or specialty, the possibility then exists that the patient or the patient's family is going to be seeking that service outside of the plan, and as such is going to bear a significant burden. So a covered item in terms of coverage becomes an uncovered item in terms of actually getting the service through the plan, and that cost can be quite extreme. So having a clear strategy and policy on network adequacy across the board is an important feature of, again, closing the loop on what coverage actually means. But I do think that the recommendation is a correct one.
Ron Klein in Las Vegas. Would it be acceptable to the committee if we said that we adopt the recommendations as proposed, meaning that we adopt the statewide regulations with a caveat that we examine those statewide regulations when they're issued to make sure they're appropriate for the exchange?
I certainly think that's appropriate, if that's what the committee wants to recommend to the full board. I mean, I don't see how we can make a recommendation on enhancing something if we don't know what it is yet.
I think there's a tremendous amount of complexity here because I think network standards for Las Vegas and Reno are different than network standards for Hawthorne. So I don't envy the people in the state who are going to try to make this work, but I would just take a look at what they come up with.
Any other comments?
Yes,
For the
Madam
record,
Chair, this is Steve Woodley. I'll just make mine really quick and brief. The only thing I agree with the recommendation as stated, the only thing I'd like to see included is to public comments point about essential community providers, so that if a requirement for outreach to essential community providers were made subject to the terms of the carrier's network contracting standards, and they accept that they be brought on the panel, because I think that's very important for your low-cost neighborhoods, underserved populations, and I think that's spoken to as well in the Affordable Care Act. So as long as we can wrap that in with some understanding that if the essential community providers choose not to agree to the carrier's standards for contracting purposes, at least the outreach has been made. I think it serves the public interest as well as the exchange.
Dr. Roberts?
Well, I just wanted to make the comment that I think since we adopted the market facilitator model, we really don't have a lot of choice except to say that we're going to go along with the Department of Insurance's network adequacy standards. I don't think it would behoove us. We're breaking that model and going beyond what we said we were going to do in the policy that we set very early in our course.
Madam Chair,
Yes.
I think we should also look at incorporating something about the use of telemedicine and recommending to the Department of Insurance that they look at the telemedicine availability. I routinely get claims for mental health telemedicine for the rural markets that, to be candid with you, I didn't even know that we were doing mental health telemedicine until I started getting these claims in. So if that's within the current state criteria for the HMO, for the sake of argument, that's great. But I'm not sure that Nevada has made the push to telemedicine as much as some of the other states have. And it would be important to know that there is a substantial availability of that being built in certain parts of the state, and it's critical for people to be treated in their own areas as well.
All right, so does someone want to make a motion then that incorporates the committee's thoughts?
I'll give it a try. Larry Mathias, that the recommendation be the exchange adopt the network adequacy standards that are adopted by the state for the entire market, and that these should include efforts to assure the essential providers and the incorporation of telemedicine and other extensions of specialty care. That's yeah, okay.
And that they be reviewed once they're available? Is that?
Yes.
Accept?
Yes.
Okay.
I'll second.
All right, do we have further discussion? Calling for the vote, all those in favor?
Aye.
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 Any opposed? Motion carries. All right, service area.
Regulation requires the exchange have a process to establish or evaluate service areas of QHPs to ensure that service areas meet minimum criteria, which include coverage of a minimum geographical area that is at least the size of a county by geographic area or group of counties defined by the exchange, unless the exchange determines that serving a smaller geographic area is necessary, non-discriminatory, and in the best interest of qualified individuals' employers. The service area of a QHP has been established without regard to racial, ethnic, language, health status-related factors specified under the Public Health Services Act or other factors that exclude specific high-utilizing, high-cost, or medically underserved populations. The Public Health Service Act requires that the state set standard rating areas. A rating area is an area in which all individuals are placed in the same rating pool for purposes of establishing rates. A service area is an area in which a carrier offers a health plan. If these areas are not synchronized, a situation could exist in which a carrier offers health plans only to regions that have the best health risks and therefore lower costs. This could create extremely high rates for individuals outside the service area and could create a disadvantage to those carriers willing to serve those areas. So the recommendation is that service areas for qualified health plans be aligned with rating areas required to be set by the state pursuant to the Public Health Services Act. So the rating areas really would be set either by the state, by the legislature, or they would provide that authority to the Division of Insurance. I'm not sure exactly who would do it, but it's market-wide for the rating areas. The service area requirements are for qualified health plans. And so, again, this is one of those areas where we don't have set rating areas yet. There are typically about 4 or 5 general areas where carriers, geographical areas in which carriers pool their rates. So, for instance, Clark County, maybe Washoe County, you might have the Carson City, Douglas, Lyon County, and then other rural counties. That might be an example of how rating areas typically are today. We're, again, not sure how this will end up, how the rating areas will be defined. I imagine they will be similar to what is done today. But again, this is one of those areas where we don't have the information yet. But because of adverse selection purposes, it makes sense. We think that the service area aligns with the rating area.
I have a concern not around the service area issue for the simple reason that we're not licensed, for the sake of argument, for HMO in Clark County. And we're licensed in limited areas for the HMO. And actually, it's interesting because some of the counties where we're licensed for the HMO, there isn't even a provider, like Story County. I think there's one chiropractor there, and a PA from the Hawk Clinic. So there's no specialist there. There's nothing. So I think it's reasonable to do this recommendation, but in terms of the qualified health plan, if someone's not offering an HMO in a particular marketplace, they shouldn't be forced to move into that business just to have a plan. That's my concern.
My question to John, after listening to your, explanation on this, are we trying to make a decision too soon? Do we need more information before, you said you're not sure what the legislature might do on this. I hate to take positions on things before we know what the facts are. And I'm just wondering, is there a reason why we have to make a decision on this one particular item today?
This is one of those implementation issues, and the difficulty is, again, I'm not sure if the Division of Insurance or the Commissioner of Insurance has the authority to make a decision on rating areas. It might have to go to the legislature. If we wait till the legislative session happens, then either it happens right up front, somehow miraculously gets done in February, or we're waiting until possibly as late as June, and we have to have the certification process moving forward. So there's obviously different ways we can go about it. The requirement of the Affordable Care Act says it at least the geographical size of a county. So you could say at least the size of a county, and then maybe revisit it later. You could sync them up and revisit it later. It's one of those issues where you have to implement without all of the information, unfortunately. We could delay it, but I don't know how long the carriers would be comfortable with such a delay. When you look at the service area having to be a broader area than what a carrier might have, that's good and bad. It could be bad because a carrier doesn't want to participate because you're forcing them into a market that they don't feel that they should be in. On the other side of that, you could say that, those populations don't have access to good health insurance, and so it broadens the access for those individuals that can't get it. So it's a difficult question to make.
Who has
Madam Chair?
the statutory authority of saying what the rated area is and what the service area is? Is that the Division of Insurance, or is it us?
The service area very clearly falls under the exchange.
Okay.
The rating area appears to fall under the Division of Insurance. However, throughout the implementation process for the Affordable Care Act, there have been issues on what the Division of Insurance is allowed to do without legislation. There are, for instance, network adequacy is in statute for HMOs, so you can't really change network adequacy standards without changing statute. And it would appear that there is a precedent there to set network adequacy standards via statute. So therefore, if you add standards for PPO, point of service, et cetera, it appears that you would have to use statutory changes to do that. Doesn't necessarily mean that's the case, but it appears that way. For setting rating areas, I don't think that Nevada has done that in the past. I think it's been up to the carrier, and therefore the who has the authority is not clearly defined. But because it's market-wide, it is very clearly outside the scope of the exchange, and it is at least the Division of Insurance, but could be statutory change.
Madam Chair, may I ask a question, please?
Dr. Klein?
Yeah. So the Division of Insurance has no geographic standards for the current plans that it licenses? In other words, are we I don't want to reinvent the wheel, obviously, and I don't think you do either. So right now, an insurance company can set up a plan and have no limitations as to the service area? Somebody can help me with that?
I think I'm going to have to ask Mr. Plain to come up here. He may or may not have an answer to that. I certainly don't. My understanding is the carriers define their rating areas and service areas.
For the record, Adam Plain, Nevada Division of Insurance. I am not sure of the answer. My recollection tells me that Mr. Hager's statement is correct, that the rating and service areas are defined at the plan level by the carriers and not defined by the state or the division currently.
For the record, Dr. Roberts, I believe that's true, but we get licensed only in the service areas that we say we're going to provide service in. And so we cannot provide service in other areas.
So going along with I'm sort of thinking this through as I speak, which is always dangerous, but going along the free market facilitator approach, could we not define a service? I mean, obviously waiting to see if there are other criteria, but could we not define a service area as that which a plan, as that which a QHP would like to serve, as long as it encompasses at least a county? Would that be sufficient?
Yes.
Again, knowing that we're going to revisit this in spring of 2015.
Yes, that would be sufficient.
This is Larry Mathias. I am concerned that this is a fairly complex area, and maybe we should table it until our next meeting. It would be possible, fully within the rules, then, for certain counties to have no plans offered. And I think that we need to think through that before we set up a circumstance like that could happen. Service areas are variously defined in Nevada law, and they're defined by other processes, including federal designation of service areas for purposes of health care, and that's been used by the State Health Division when they look at the adequacy of the HMOs. So I think maybe we need a little more background, a little more, and to give this a little more thought. If there's not a pressing need that this must go to the board at its next meeting, we could revisit it. So if that's okay, then I'll make a motion that we table this until the next meeting.
I'll second that. This is Vicki Mayville for the record.
Okay, we have a motion and second on the floor to table this recommendation until our next committee meeting. Any discussion on that?
Madam Chair, I think that we should have the Department of Insurance respond to us very specifically around the licensure for how the PPO licensure works, how the HMO licensure works, what they currently do for rating, what they currently do, and have the carrier submit for what they call area factors that might change the costs in and outside the count of the base rates for the plans, so that we have a better idea exactly how the process works today.
Well, and I also want to make sure that if DOI is responsible for creating those new rating areas, and we're uncertain whether we do the service area, or maybe they do.
For the record, John Hager, I am certain that we set the service areas for the QHP. The federal
Okay.
law says the exchange will set the service area for the
Okay.
QHP.
Then I would think we need to have a great deal of coordination between these two agencies to make sure that we're not creating any adverse or advantageous selection within when we create those areas. Those would be my comments. Any other comments on the motion? Okay, so we have a motion and a second. You've got the names on them. I'll call for the vote. All those in favor?
Aye.
Aye.
Any opposed? Motion carries. This recommendation will be moved to our next committee meeting. Next item on the agenda is standalone dental plans.
The Affordable Care Act allows an issuer that provides only dental coverage to offer such coverage on the exchange as a standalone dental plan. Furthermore, if an exchange offers a standalone dental plan, then the other qualified health plans on the exchange may be certified as a QHP, even if they do not include the pediatric dental requirement of essential health benefits, because that child could get that coverage from the standalone dental plan. In May, the board approved the Finance and Sustainability Advisory Committee's recommendation to charge user fees for standalone dental products. User fees for dental products would be charged on a per member per month basis and would be proportionately smaller than rates charged to QHPs. The board also approved a similar recommendation for standalone vision QHPs. However, the exclusion that allows for a QHP to be offered on the exchange without pediatric dental coverage does not apply to pediatric vision coverage. Therefore, any standalone vision QHP would only apply to vision coverage for adults. Now, we have received some comments from vision plans that have indicated that there is possibly an exception to this when you read through several different laws, and so we're looking through that. But staff will work with the Division of Insurance to create the proper procedures for certification of standalone dental and vision QHPs. There's no actual recommendation for this one. Again, it's just to complete that section of the regulation.
Do we have any questions from committee members? All right, let's move on to recertification.
Recertification of a QHP should be similar to the initial certification process, though those aspects of a QHP that did not change since the previous certification or recertification would not necessarily require review. The recertification process would be aligned as much as possible with the rate review process. Staff will work with the Division of Insurance to determine appropriate processes and timelines for recertification. And so this recommendation is basically identical to the certification recommendation. Allow the Division of Insurance on behalf of the exchange to recertify health plans as QHPs to be offered on the exchange.
Okay, I'll open them up for discussion. Questions from Las Vegas? Questions here in Carson? I guess my only question would be, how often do the QHPs need to be recertified? Is it annually, every other year, every 3 years? What are going to be the dynamics of that?
I would guess that it would be every year, because part of it is the rate review process.
I would tend to agree with that.
But John, we're talking about both the certification and the accreditation process here?
So this is just recertification, which is separate from the NCQA URAC accreditation. To be certified or recertified, you have to have an accreditation or a letter of survey for the accreditation in place. Yes. The accreditation, I believe, typically happens once every 3 years.
Yes.
So it's not required that you get re-accredited every year, simply that you are accredited, but the certification by the Division of Insurance, if this gets approved, would be every year.
Right, then the only amendment I would put in that recommendation is that it be recertified annually, so it's clear how often that would take place.
I would second that.
I'm not making the motion, I'm just making a recommendation, so.
So I will second your recommendation once it becomes a motion.
Okay. No, I don't think
I'll
I'm
second the
supposed to be
second.
making motions.
Larry Mathias, I'll make the motion that we accept the staff recommendation and also by inserting that this be done annually.
Sorry, Madam Chair, I'll be delighted to second Mr. Mathias.
Thank you both. Any further comments?
John, is September 15th early enough, since the open enrollment is every year around October 15th?
I'm sorry, what?
The exchange must complete the certification on or before September 15th of the applicable calendar year. I'm asking if that gives you enough time to change all the information that would go into open enrollment if somebody was not recertified.
That probably does not give us enough time, but we will make clear through the administrative process and our communication with the carriers what time we need to be able to make the deadlines for October 1st. I think by September 15th we're already in testing mode.
Any other comments? Then I'll call for the vote. All in favor of the motion?
Aye.
Aye.
Any opposed? Motion carries. Moving on to decertification.
So the regulation requires that exchanges have a decertification process. The Division of Insurance currently has oversight over health plans offered in Nevada. As complaints or issues arise, the Division of Insurance has the authority to revoke the authority of a carrier to offer health insurance coverage. The exchange could utilize these processes. Staff will work with the Division of Insurance to determine appropriate processes and timelines for decertification. You can see that I copied and pasted a lot. The recommendation is to allow the Division of Insurance on behalf of the exchange to decertify QHPs that cease to meet the requirements of the exchange, the Division of Insurance, and the Affordable Care Act and its regulations.
Any discussion from Las Vegas?
Ron Klein, just a clarification. Is the exchange the one decertifying the plans, or is the Division of Insurance decertifying the plans?
So in this one, similarly to the certification and recertification items, while the regulation requires that the exchange do it, we could have a memorandum of understanding through this policy process and then through tighter agreements with the Division of Insurance that the division do it on behalf of the exchange. So the recommendation here is that the Division of Insurance decertify a plan as appropriate based on again, processes that are, of course, yet to be determined.
Based on statute, do we have that authority, or does the Division of Insurance have that authority?
The exchange, based on the Affordable Care Act and its regulations, has the authority, is required to have a decertification process set up. We have the authority to work with other entities via memorandums of understanding, contracts with vendors, or understandings with other agencies to utilize services of other agencies as necessary to make sure that we can carry out the functions of the exchange.
Okay. So my question would be, if we have an insurance company that we don't think is providing proper level of care or funding network adequacy, however you want to term that, and the exchange board says that it should be decertified, but the Division of Insurance says that it should not. How does that work out?
I suppose at that point we'd have a problem.
I asked the question.
Sure. So certainly the concern would be if the Division of Insurance did not do what the board felt was necessary, so you could either allow the Division of Insurance to do this, or you could provide a caveat that says that the board can decertify a plan. Certainly before it even got to the board level, I would hope that the complaints that we receive would be discussed between the exchange and the Division of Insurance, so it doesn't even get to that point, but that it certainly could be a problem.
How does this, and just sort of maybe getting too much into the weeds, how does this work in terms of the enabling legislation, as SB 440, if I'm remembering correctly, that says that we're not to interfere with Division of Insurance operations?
So we are not saying that we are, if the exchange decertifies a QHP, that's not to say, whether the Division of Insurance does it or the exchange does it, if the Division of Insurance does it on behalf of the exchange, if a qualified health plan is decertified, that doesn't mean that they can't continue to offer coverage outside the exchange. Therefore, we are not impeding the ability of the commissioner to regulate insurance within the state. We are simply saying that a plan is no longer a qualified health plan and can no longer be offered on the exchange.
Okay. So your recommendation on this was to give this process to the Division of Insurance or to keep this with the Health Insurance Exchange?
The recommendation was to give this process to the Division of Insurance. The thinking behind that is that the Division of Insurance currently deals with appeals and complaints by consumers to carriers. They work with carriers when they become insolvent. A lot of the issues that may require the Division of Insurance to, I don't know if it's called delicensing or make it so that a carrier cannot provide insurance to the population. A lot of those processes are already in place at the Nevada Division of Insurance. So I guess the question would be, does the committee or will the board foresee a situation in which the board does not want to allow a carrier to offer a qualified health plan for whatever reason, even though the Division of Insurance might allow that plan to continue on? With the free market facilitator model, it would seem that those processes would be more aligned. If the board were to migrate into an active purchaser model, at that point you would certainly want to bring the certification or decertification process, over to the exchange at that point.
Okay. I guess then I would respectfully disagree with that recommendation. I would not want to see the Health Insurance Exchange cede that authority to the Division of Insurance.
I guess my other question would be, if this committee adopted the regulation, how do the appeal rights go forward? Does the appeal go to the exchange or does it go to the Division of Insurance? Since we have the authority to decertify, I think
you can create a process where they are responsible for the decertification process, but then the final appeal can come back to the committee. So you can probably create anything you want in terms of levels of appeal.
I think that probably is more of a legal question, and unfortunately our DAG just had to leave for another meeting. But I think those things need to be worked out, because I think there are some real statutory requirements as far as appeals go, and one agency has difficulty appealing the decision of another agency. So those would be my thoughts. I mean, at least as part of the discussion.
For the record, John,
I'm sorry to interrupt. What's our process for recertification? Because obviously, if you're going to recertify every year, then not recertifying on a yearly basis, then not recertifying somebody is essentially the same as decertifying them, since it's an annual process.
I think the certification, recertification process, while there is a process that has to take place, it's more passive, whereas a decertification process would be a positive push by an entity to decertify a plan or a carrier. It might make sense to have the exchange retain the decertification ability. Maybe the board has a final say on decertification. However, if a plan, if the Division of Insurance foresees or comes across a situation in which a plan becomes insolvent or otherwise is no longer allowed to do business in Nevada or not allowed to provide certain plans in Nevada because of whatever reason, obviously those plans would no longer be certified QHPs. There would have to be a decertification process that is attached to that. So maybe there are two types of decertification. One would be initiated by the Division of Insurance because of failure to comply with Nevada statute, and one would be a final approval or final authority. So let me back up. The process for the Division of Insurance, if you can't do business insurance, you can't be a qualified health plan. So obviously that makes sense. So if they revoke the authority of a carrier to provide a qualified health plan, it would make sense that the decertification goes through, in that case, through the Division of Insurance, because they won't be able to provide insurance products at all. If there is a reason that the board feels that a QHP should be decertified, then perhaps we need to build a process for that that enforces some stricter standard than what is required by the Division of Insurance. So I guess it's separating out those two types of decertification.
My concern would be the opposite, that the Division of Insurance says, yeah, you're fine to do business here, and the health insurance exchange, for whatever reason, chooses not to do that. So what happens when the Division of Insurance recertifies and the health insurance exchange decertifies, all within a week of each other, just for fun?
The exchange has the final authority on what licensed carriers that are certified as QHPs have the authority to sell products through the exchange. So if the board determines that despite a certification as a QHP, it feels that a carrier should not be offered as a QHP, we can keep that carrier from offering its product on the exchange because it's our exchange. If you do not offer a product on the exchange, if a product is not offered on the exchange, by definition it cannot be a QHP. So even though it's certified by the division as a QHP, if it's not offered on the exchange, it is no longer considered a QHP. Could still be offered off the exchange, but cannot be offered inside the exchange. So in reality, the board has the authority. We would have to set up a process. I think this would be through regulation. It would have to be pretty solid process on how the board would determine that a carrier should no longer be offered on the exchange.
Well, how about amending your recommendation to say, allow the Division of Insurance on behalf of the exchange to recommend give them the ability to recommend decertification for QHPs, and then I think you can decide later about exactly what the mechanics are. I'd also say that they could make a decision, the Department of Insurance, to recommend that a decertification of a particular carrier or plan be done because they haven't put in essential community providers, but that doesn't necessarily mean that they couldn't offer something outside the exchange. So for the sake of argument, if somebody made a decision that they needed to terminate one of the Indian clinics because they couldn't credential the providers inside that clinic to the safety of their membership, then it wouldn't necessarily mean that they couldn't offer a product outside the exchange. I'm just.
Dr. Ash Jackson, I apologize. We lost your entire statement other than the last 5 seconds. We
Okay.
lost sound down here.
Okay. I was just saying that one of the things that it's required is essential community providers. And suppose a health plan originally put in essential community providers as one of on the federal Indian reservations for the sake of argument, and now a health plan feels that it can't continue to keep those providers in the network or because quality issues that have arisen. So there could be a decision that you might not want to keep those providers in your network, and therefore you could potentially be decertified from the exchange, but it shouldn't limit your ability to operate your plan outside the exchange. I mean, that would be, to me, one of the things that would cause a decertification that wasn't onerous.
Our meeting will be disconnected in 30 minutes.
They're just notifying us that we'll lose everything in 30 minutes. So.
And we've lost sound to the south. I can see your lips moving, but we can't hear you. If there's LCB staff is listening, you can't hear us either?
We just heard you just now, John.
Okay, we've got you back.
Okay, so I guess I would agree with Dr. Ash Jackson, as John, as you said, that whatever the health insurance exchange does doesn't affect the ability to plan to operate outside of the exchange. So that's that we're in agreement. I guess I would word the recommendation more along the lines of, the health insurance exchange retains the authority to decertify QHPs that cease to meet the requirements of the exchange in consultation with the Division of Insurance. But I would speak strongly in trying to retain this for the health insurance exchange. I would not cede this authority to the Division of Insurance.
Okay, we've got a motion. Does someone wish to second that motion?
I'll second it.
Okay. Do we have any further discussion? Now I'll call for the vote. All those in favor of the amended recommendation?
Aye.
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 Any opposed?
Nay.
All right, we have one nay. Is that Dr. Roberts?
Yes, I didn't get a chance to discuss this motion any further. I guess I'm looking at this in terms of our policy as market facilitator. I don't see that not ceding the Division of Insurance the action to decertify QHPs that cease to meet the requirements of the exchange. I see that as a potential problem between the Department of Insurance and the exchange and the carriers, for that matter. If they are going through the Division of Insurance to get certified and recertified, then the same agency should be tasked with decertification if necessary.
Would you like to comment?
Thank you, Madam Chair. So this may be helpful, and this is where I was going with the thought, is John, through the exchange, could probably draft a fairly detailed memorandum of understanding with the Division of Insurance and delineate the roles and responsibilities by which the Division of Insurance decertifies for insolvency, and a number of examples that would readily come to mind. And then we preserve the right on the exchange side to decertify for situations involving customer service or lack of meeting the requirements that the exchange stipulates. So I think that could be addressed, and that hurdle could be overcome fairly easily. It'll just be a matter of John and his staff meeting with Scott Kipper at the Division of Insurance, working on an understanding of the roles and responsibilities that would satisfy the terms of the motion, as well as your concerns as well, Dr. Roberts.
On the other hand, the memorandum of understanding could also include those concerns that the exchange had that were outside the statutory requirements of the Department of Insurance, that were strictly exchange requirements, that we could give to them and say, you have to, for the QHPs, you have to apply this too.
I think that we've had our motion approved, so, and I like the discussion afterwards, but I'm going to move ahead to the next item on the agenda, which is the transition of care.
For the record, John Hager. So this one actually wasn't necessarily in the regulation, but committee members have indicated that there are concerns about transition of care standardization and churn, or I guess how churn affects transition of care issues. Discussions with carriers indicated they are committed to providing consumers with appropriate coverage through their insurance, through individuals' insurance transitions. Many carriers apply standards beyond those required by statute. The statutes for individual and small group coverage indicate that, except for provided in that section, an individual who is insured by an individual or small group plan who is receiving medical treatment for a medical condition from a provider of health care whose contract with the insurer is terminated during the course of the medical treatment, the policy must provide that the insured may continue to obtain medical treatment for the medical condition from the provider of health care pursuant to this section if the insured is actively undergoing a medically necessary course of treatment and the provider of health care and the insured agree that the continuity of care is desirable. The provider of health care is entitled to receive reimbursement from the insurer for the medical treatment the provider of health care provides to the insured pursuant to this section if the provider of health care agrees to provide medical treatment under the terms of the contract between the provider of health care and the issuer with regard to the insured, including without limitation the rates of payment for providing medical service as those terms exist before the termination of the contract, and not to seek payment from the insured for any medical service provided by the provider of health care that the provider of health care could not have received from the insured were the provider of health care still under contract with the insurer. And that coverage applies to the later of the 120th day after the date the contract is terminated, or if the medical condition is pregnancy, the 45th day after the date of delivery, or if the pregnancy does not end delivery, the date of the end of the pregnancy. The requirements do not apply to a provider of health care if the provider of health care was under contract with the insurer and the insurer terminated that contract because of medical incompetence or professional misconduct, and the insurer did not enter into another contract with the provider of health care after the contract was terminated. Furthermore, Medicaid managed care organizations have certain contractual requirements they must meet. Both Medicaid and the Division of Insurance have indicated that the contractual and statutory standards in place should result in smooth transitions, though it is understood that procedural errors occur. Staff is working with Xerox to determine if a medical survey provided during enrollment is appropriate so that the exchange can provide information to an incoming carrier. However, staff is concerned that this may scare away individuals who don't want to reveal their medical situation. The recommendation is to provide guidance to staff regarding how or whether further regulation should be required for transition of care.
So, John, these are two different things. The the first transition of care in terms of the termination of provider is pretty much the standard as I understand it, provided the provider agrees to accept the treatment and let the patient continue the treatment. The second thing where you have is where the staff is working with Xerox to do a medical survey so that the exchange can provide information to an incoming carrier as to who is in current treatment for a disease is a different story. That's a transition form that for the sake of argument, we get sometimes when we're taking over a group and they want to tell us they're in the middle of treatment with somebody, et cetera, et cetera, et cetera. So I don't, to me, I mean, I personally have no issue with how it's being done today in terms of the provider termination. In terms of the member termination, can you tell us how much notice we would have for enrollment period to be able to get this information after the patient's made their wishes known as to which carrier they're going to sign up with?
So if I guess I should ask, you're saying that if we provide a medical survey to provide that information to the carriers?
You said that you think it's going to scare people away, and I tend to agree with you because they're going to perceive it's medical underwriting, which is not permitted in the exchange. So if for the sake of argument, you tell me that you're going to get, that you'll have, that an open enrollment goes from October 15th to December 15th. I don't know what that period is. And then each carrier makes available a standard transition of care form, which you could certainly decide to have that the member could put in after they made a decision, then each carrier could process that information, and it wouldn't perceive to be punitive.
So the open enrollment period, the initial open enrollment period goes from October 1st through March 31st. Coverage is starts no earlier than January 1st. To get coverage starting January 1st, you have to enroll in a plan by December 15th. So the carrier would have basically 2 weeks from enrollment to the start of coverage, and so if we were to determine that we should provide a medical survey, the carrier would, the individual would theoretically do that at the time of the enrollment. For any coverage that began after that, there is a delay in enrollment from 15 to 45 days. So the time varies when the carrier would get that information, the oncoming carrier would get that information. The other thing that we've looked at potentially is being able to get this through the health information exchange. We obviously don't have authority over that, but that might be something that's coming in the future. The ability to get that information from the health information exchange. So there's several ways things that we're looking at possibly doing, but again, not sure if that will make sense. Yes, you're correct. There is no medical underwriting, but the perception will be there that you are being medically underwritten. That's inside and outside the exchange as well, but the concern will still be there. And I apologize for inserting the wrong statute.
Dr. Roberts, for the record.
Dr. Roberts?
I think one of the problems with giving a survey once a year is that it doesn't take care of the other populations, such as people who move into the state or Medicaid beneficiaries who churn out of the Medicaid program. These things happen all year long. And if they are not given a survey, then the transition of care is going to be very difficult for the new carrier.
For the record, John Hager, so the example I gave to Ms. Jackson was for open enrollment. If we were to do the survey, it would be during any enrollment, whether it's open enrollment or a special enrollment. It would be the same process. Regardless of when you did that.
So do you believe that this, to put something in place for patients to be treated consistently, further regulation is required? Or is it a policy that you could put in place?
If we were to do the survey, and again, I need to make certain that we understand that we might not do the survey because we don't want to reduce enrollment significantly. You might scare a few people away, but not very many, so you do it. But if you scare half the population away because they're worried about being medically underwritten or not getting coverage, then we certainly don't want to do that. So it's difficult to say whether or not we would do that. If we do the survey, that would simply be, we would be able to do that through the administration of the exchange, and we don't require regulation. if the committee feels that there is an underlying issue of people not getting the appropriate coverage when they transition from one plan to another plan, it could make sense to add regulation. Again, we have to balance the addition of regulation and the potential cost or administrative burden that might create versus protecting special populations. And so that's why the recommendation is pretty vague, is provide guidance to staff. I would, if the committee has concerns about specific instances, it would help us to understand what to do.
I'm going to make a suggestion because we're getting a little tight on time here, and I want to make sure we have enough opportunity to close out the meeting with public comment. I know this topic has been on the table since our very first meetings, and so I think we could take a whole meeting and try and discuss how to resolve this issue. What I think that staff is asking is, we know that this is an important enough issue that I would suggest that we take written input from people on how we think we might resolve this issue if we can, and that if it develops enough that we take this into rulemaking, if we have the authority of doing that. But that would be my suggestion, because I don't think in the amount of time that we've got here this afternoon that we'll make a pinhole into the importance of this issue.
Madam Chair, I'll make a motion that we table this item at least until our next meeting, and that we solicit written comments on the issue of continuity of care, things that create discontinuity, and whether or not regulations in addition to the statutory provisions are needed.
And I would further say that we would accept input from everyone, including, not just the committee members. So if anyone of the general public wants to participate in
yes,
that,
I think we should
would do
solicit
that.
as many interested parties as possible.
Ms. Mayville, are you
Oh,
trying
I
to
was
say?
going to second the motion.
Oh, okay.
I was just second.
Thank you. And further discussion from members? All right, I'll call for the vote. All those in favor?
Aye.
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 Any opposed? Thank you. The motion carries. Do any of the members have any other discussions for, I think we've got two items that we've put out to future meetings just by the action of two of our motions here today. Are there any other topics that you want to bring to Mr. Hager's attention?
Ron Klein in Las Vegas.
Yes, Dr.
Just
Klein.
a question, Mr. Hager, are you planning at any point of bringing up Mr. Sasser's recommendations to either our committee or to the Exchange Board?
I can bring them up here. They actually fall in there. For the most part, they fall
Do
in
you
this
want to wait?
agenda. So real briefly, so we discussed today the limiting the policies to 1 or 2 years today, so we explicitly provided that information. That was the first bullet point. The idea of offering at least one plan in all tiers, which includes the catastrophic bronze and platinum plans. The committee's vote, or I believe it was the committee and then the board, voted to simply require the silver and gold plans be offered. I will say that we are reviewing this with the insurers because this is an adverse selection issue. So the insurers would obviously have concerns about this if they are concerned, and so we are we speak with the carriers pretty much every other week to discuss these issues, and so we've started to bring this up with them. So if the carriers are concerned with that, we will probably bring that one back. Issuers should be required to offer QHPs in all. So that was that one. The standardized plan. The issue with the standardized plan, we specifically discussed to not require a standardized plan, that we would again review that in several years. We have reviewed the reports that were referenced, and the issue of the coinsurance is not just a coinsurance issue but also a deductible issue. If you say that I pay 20% of the allowed maximum. I have no idea what that number is. I want to know that. Well, you're going to have that same issue with your deductible. You're not going to know what the cost for the MRI is going to be. So regardless of whether we eliminate coinsurance, the deductible issue remains. The idea of incentivizing insurers to meet strict standards, I suppose the question, if the committee has concerns about that, is what those strict standards might be, and how far do we go with those standards. Certainly the idea of the last agenda item about other discussions for future meeting agendas, would be happy to take any recommendations that the committee might have to implement stricter standards. And then to explicitly add a requirement that if any variation of benefit design cost sharing is permitted, all QHPs must be tested for possible discriminatory benefit design. It is required that a plan not be discriminatory. That should be part of the certification process. What exactly discriminatory benefit design is, we're still waiting for a definition from the feds. If anybody has a recommendation on how to test for that, I'm sure the Division of Insurance and I would certainly be happy to have that definition. It's difficult to say exactly how you test for that. So they are items that we've pretty much discussed or are going to do through the certification processes. If one of these items the committee would like to take a better look at, we'd be happy to do that.
Thank you.
Any other discussion items for Mr. Hager? Okay, being none, I'm going to open it up for public comment again. Dr. Klein, will you help me there in Las Vegas, please?
Yes, be delighted. I see no public comment in Las Vegas.
Thank you. How about here in Carson City? Just remember to identify yourself for the record, please.
Thank you, Madam Chair. Once again, John Sasser for the record. First, I want to thank the advisory committee for adopting the recommendation on the time limiting and looking at things in spring of 2015. I really appreciate that. And also for the summary that Mr. Hager gave of the other ideas. Number 4, I said earlier I'd withdrawn, so but I appreciate you continue to look at those, especially in terms of the risk adjustment and bringing those back. Just a quick observation. By adopting recommendations 1 and 2, you've said that any plan can come on that meets several requirements, one of which is compliance with the ACA. And second, you've now decided by MOU to have the certification be done by the division. So that sort of puts the division in the position now of being the body other than this body of interpreting the ACA and deciding whether plans meet that. And I guess in terms of your role and your MOUs, I would take a hard look at that. 2 examples. One, this issue of essential community providers is not an issue that DOI is used to dealing with. It only is under today's law for HMOs for Medicaid providers. And there is a lot of history there, and I think there are going to be some policy decisions that need to be made. It's not going to be a black and white rule from the feds, and other states are looking at that. So I don't know that you might not want to keep your hands on that. And then the other is the discriminatory design issue that we just talked about. I have parents of kids with, and some adults now with Down syndrome, for example, saying, we're left out under this benefits package if they go to default for Plan A. Who do we talk to about that? Who do we complain to? Is it the role of the exchange? Is it the role of the insurance division? Is it the role of the federal government? And hopefully that will be clarified when the federal regs come out. But there are a lot of people that are very concerned about their kids being left out in the cold. And I hope they have an avenue to address that issue. And I would hope that this body would not, in essence, wash your hands of it and give it just to the division. So anyway, those, thank you very much for your consideration of my ideas today.
Thank you, Mr. Sasser. Anyone else here in Carson City? Do we have anyone on the telephone?
Yes, can you hear me?
Yes. Would you identify yourself for the record, please?
Sure. My name is James Mullen. I'm with Delta Dental Insurance Company. I'd also like to express my thanks to the committee for taking up this very important topic on certification standards. As to the discussion around standalone dental plans, I just wanted to point out that we'll be happy to supplement a previous document we supplied to Mr. Hager on standards that are in the regulation, how they relate to dental plans, and to what extent they should be required. In the standards as set forth in your talking points today, it takes careful note to say that a standalone dental plan should meet QHP certification standards except for any requirements that cannot be met because the plan is only covering the dental benefits. So such things as, for instance, accreditation. There is no accreditation of dental plans today. Essential community providers, they don't I don't think at all meet in the definition in the federal rules. I think there are 340B providers. They're not inclusive of dental providers. And we can have further discussion with that. But since the recommendation of the staff is to involve now the Department of Insurance in a more robust way here, we certainly would like to work through the exchange and staff and directly with DOI staff to what extent we are allowed in order to just have this discussion, and again, be happy to supplement what we supplied earlier. It tends to change, and I think, as Mr. Hager pointed out, we are probably going to get a lot of rules potentially after the election here in November, December, and so these things will likely be fluid and continue to change. So we'll continue to keep updated with this type of information. So thank you very much.
Thank you. Do we have anyone else on the telephone for public comment? Hearing none, I will adjourn the meeting. Thank you, committee members, for all of your hard work. I always appreciate all your input. I know how much time you put into this, and we appreciate it. Thank you.